thank you for joining us today. We've got an excellent session planned, which is going to be focusing on acting on the questions that are most important to patients. And yes, thank you very much, Caroline and Tracy, for joining us today and giving us an insight to what has been going on at Newcastle. So without further ado, I'm happy to hand straight over to you, Tracy.
Excellent, thank you very much. So as Hannah said, my name's Tracy Scott. I'm Head of Patient Experience here at Newcastle upon Tyne Foundation Trust, and I've got Caroline with me.
Hi, I'm Caroline McGarry, Patient Experience and Involvement Officer at the Trust.
So I thought it might be helpful to start with a little bit of an introduction of who we are in Newcastle and some of the challenges that some of our patients feel and experience on a regular basis. So we're quite a large city centre trust. We've got two sites based in the city centre in fairly close area to each other, and we also have quite a diverse community service. We've received 2 outstanding CQC ratings, and the latest one being in May 2019. We employ in the region of about 18,000 staff, but that number did increase quite substantially over COVID because we're led on some of the COVID vaccination hubs, and we see over 1.8 million contacts per year. And when we're looking at the population of Newcastle, we are challenged with health inequalities. We've got an absolute huge diverse patient group. We have the highest rates of poverty, unemployment, poor health and early death across England. We've got an average reading age of about 9, so that kind of describes some of the challenges our patients can experience when accessing health and social care. As I say, we are one of the most deprived areas in England, and 30% of our children in our local area across Newcastle live in low-income families. And again, I kind of touched upon the life expectancy is far lower than the national average for both men and women. So those health experiences and situations absolutely contribute to the way we are under pressure to deliver services and make sure that our services are accessible to that kind of diverse patient population. So our team's quite small, so we've got about 14 staff who sit within the patient experience team, but the patient experience team's quite diverse. So we have our complaints, we have patient experience, so that's all of the requirements of capturing, measuring and analysing patient experience. And we've also got equality, diversity and inclusion for patients feeding into our service. And that can in itself be quite a challenge because complaints tend to receive the most resource because we're absolutely, monitored and we've got to be compliant with the way we manage our complaints. But I think the beauty of bringing patient experience, complaints and equality and diversity together is that we make sure that that information and that data speaks to each other. So when we're looking at service improvement, we don't look at anything in isolation. Complaints absolutely can drive, some of our service improvements around patient experience. But if we're looking at troublesome areas, we look at how we can use patient experience measurements and tools to kind of do deep dives. And then we'll also look at from an EDI point of view about, sort of what our vulnerable groups are experiencing within that area to not only capture where we've got troublesome areas, but also actually where that good practice is. Because as I keep on saying, across the organisation, complaints are very, very important, and we absolutely need to listen and respond to our complaints. But actually, we also get some very, very good patient experience feedback. And it's so important to not rest on our morals with that, that we have to keep on challenging ourselves to think about how we're able to improve going forward. So I'm going to hand over to Caroline next to kind of, sort of do some sharing of information with regards to where we are on the National Inpatient Survey. And then I'm going to kind of talk through what we did during COVID that might have or may not have had an impact on our good results for this year. Over to you, Caroline.
Thanks, Tracy. Can I have the next slide, please, Hanan? So the National Patient Survey, we have historically done well with our scores, and it's always hard to say what attributes to a certain score and to how well we do, but to put it into perspective for people who use Picker, you can see the average overall positive score chart. We are at the top end of that, and for many years have been. I do understand that the trusts largely above us are those that are specialist trusts. So coming from an acute trust that offers a range of services and diverse patient groups, it is good that we score so highly. Our results are looked at by our patient experience monitoring group that Tracy just described. If we can just have the next slide, please, Hannah. One area that we've noted didn't do so well this year, and I think that's kind of part of the national picture, is the historic positive score. So we did do in the minuses this year, which might be an area of concern, but if we're looking at how we can improve on scores such as 99%, it is hard to add to that. So we got 99% in things like confidence and trust in doctors and nurses, cleanliness, really important areas to patients. So it's not necessarily when we looked at that chart that it is an area of concern, because those who are getting a positive change may not have done so well the year before. So that's what we have in mind when we look at the Picker results. I think we're always keen to look at a theme or a trend and to see where we can improve. Next slide, please. So one real area of focus from the Picker reports is the improvement maps that our patient experience monitoring group will get, and I kind of look at in a bit more detail to see what we can pull out and focus on really. So when we're looking at developing action plans, what we're looking at is the quadrant where we don't do so well, but are the areas that are important to patients, and that's where we would want to prioritise our actions. Fortunately, when we looked at that quadrant this year, we didn't score any results in that area, which is really heartening for us as a trust, especially with what's going on in the world, really. So for the focus of this presentation, the areas that we do well that are also important to patients is that top right-hand quadrant, and the next slide pulls that a bit out in more detail and lists the questions where we resulted in that quadrant. So there's some real relationship aspects of patient care that are important to patients and where we do well. So things like respect and dignity, confidence and trust, getting help from staff, involvement and information given at the right time and the right quantity. So with that, I can hand over to Tracy, who will go through some of the main activities that we've done in the last year that may or may not have impacted on those positive results.
Thanks, Caroline. So that's brilliant. Thank you, Hanan. So I think I've got to start with, I don't think we've done anything different that anybody else hasn't done. You know, I think this period of time has been absolutely hugely challenging for all NHS organisations and for people in general. And I think we were as responsive as what everybody else has been. Historically in Newcastle, we've always performed extremely well in any kind of patient experience measurements. And, you know, coming back to our complaints, we don't receive a lot of complaints in comparison to the activity that comes through our doors. So I suppose today is not about, you know, what are we doing different? Because I genuinely don't believe we're doing anything different to what anybody else is doing. What we have done during COVID, we had what was called a patient-centred care model. And what we did is we established a bronze, silver, gold command centre that met on a daily basis and looked at things like staffing and COVID outbreaks, IPC work, you know, that kind of thing. And everything was addressed at the bronze model. And anything that we could be reactive or proactive to, we absolutely implemented on that day. If we couldn't, for one reason or not, then it would go up the system to silver and gold command. And I think this absolutely had a huge positive impact on patient experience, because what they looked at was things like bed activity, you know, transitioning patients from one area to another, closing areas if necessary because there had been a COVID outbreak. It also looked at things like our staffing. So again, we would have been no different to any other organisation across the country that, you know, we were losing staff on a daily basis, and they were having to shield for long periods of time. So we were having to train staff quickly to work into areas that weren't their specialist areas, and make sure that our wards were being safely nursed across the whole organisation. And I think the reflection in the inpatient survey has said that actually we've probably done that well, and our patients were satisfied during that period of time that we were attempting our very, very hardest to make sure that care wasn't compromised wherever that could be possible. The other bit which I think had a huge impact on our patient experience is the amount of staff support hubs that we immediately put in place. So that was things like, you know, access to free meals, local accommodation for staff, you know, if they were working out of area, if they had vulnerable people at home, and we were worried about that kind of spread of potential infection if you were working in a clinical area. We put massive amounts of resource into things like chaplaincy and pastoral care, you know, so I think improving the support and the resources from a staffing perspective absolutely must have had a huge positive experience for our patients as well. The other bit for us was we had patient information about things like raising concerns, about our PALS information, and then we also had information with regards to our local measurements of patient experience, which we call Take 2 Minutes, and we had our family and friends cards. And I think what that kind of does is it segregates people into, I want to give feedback or I want to make a complaint. So our team kind of developed this patient experience matters leaflet. So the patient experience matters signposts patients to different opportunities for them to be able to offer feedback. So it might not be a complaint that they want to make. They might have just wanted some information about visiting, or it might have been some information about coming in hospital and how we were protecting patients. It might have been concerns around accessibility. So we get a lot of patients during COVID that were really struggling to come into hospital because things like our translation interpretation service had been impacted. So, you know, we had a lot of questions as I don't speak English, or I'm a BSL user, but I still want and need to come in and access your services. So that patient experience matters leaflets, I think, might have helped because it signposted patients at a very, very early stage of what they could expect to us, but also give them that signpost and information of where to go to should they need some help. The patient experience team worked slightly different during that time. So we had what was called a helpline. So that we kind of opened our doors to, if you are struggling with anything and you just need some help, give us a call. And again, we thought we'd be absolutely inundated with calls and inquiries for that. But we weren't. That there was an increase of activity to our department, but nothing I would say of a substantial difference. And the inquiries that we got, we were able to signpost on a more regular basis. Kind of coming back to the interpretation and translation, in Newcastle, our model tends to be 80% of our patients will have a face-to-face interpreter, but again, that wasn't a possibility, so we had to quickly put a quality improvement project in place to ensure that staff had easy access to telephone interpretations and virtual interpretations. And again, we haven't seen an increase of complaints or inquiries with regards to that. So again, we're making the assumption, and again, I don't want to sit in our morals about, you know, that those services were still accessible to our patients. And probably to add to that, we've got fantastic collaborative working relationships with some of our local stakeholders with regards to protected characteristics. So places like HARIF and elders councils, our maternity voice partnership. So again, we were trying really hard and continue to try hard to get messages out to patients around accessibility and signposting, and probably to give them reassurance that that the trust was here and that we were still delivering services, and it might look different and feel different, but actually their patient safety was still of the most paramount concern to us, you know, so during COVID and continues to be, you know, in the future. The other bit of work we did around was about keeping in touch. So like everybody else, we had to restrict visiting, you know, very, very quickly. And this had a massive impact on not only the well-being of our patients, but also on staff, because they struggled, you know, with this idea that they weren't involving family members, and, you know, they wanted to. And then obviously family members and friends, you know, weren't seeing their loved ones. And you know, over a couple of weeks, that deterioration of seeing that person was detrimental, you know, to everybody, and the impact of that was absolutely huge. So what we did is that we purchased quite a few iPads, and we implemented virtual visiting. So every single patient on every single ward would be offered a virtual visit via the iPad, and families and friends could pre-book a visit, so they knew they'd be visiting at 2 o'clock. And our staff really embraced this. And really encouraged our patients, you know, to have a virtual visit, and they could be supported. So the staff nurse could be with that patient during that visit. So again, if the family had any questions with regards to ongoing care or any shared decision making, then they were still fully involved with that. But some patients wanted to be left alone. They wanted their visit to be private. So again, we offered, you know, that opportunity should patients want a private visit. That was absolutely fine, and they got a private visit. We also, on our bedside televisions, at that time we were contracted to Hospidia, and I absolutely appreciate from a patient perspective it's quite expensive, and bearing in mind, you know, sort of the level of poverty and low income families we've got, that was a huge concern to us. So we made some of our TV channels free of charge through our charitable funds through the trust, and we also offered outgoing telephone calls free of charge. So although people, when they were ringing in, were still charged, patients could ring out. So, you know, if they were anxious, if they were worried, if they were concerned, or if they just wanted, you know, to speak to somebody that they loved and missed, then they could do that free of charge. And again, I think that had a huge positive impact on their whole experience. The other things we do, and again, it's probably no different to what everybody else has done, we implemented at short notice email contact with the wards, so non-clinical email contact, and people were sending things like photographs through, poems through, you know, so making sure that patients were still part of what was going on in the outside life. You know, babies were still being born, you know, people were still, you know, sort of having fun in their own houses, you know, during lockdown, and actually being able to share that with your mum or your dad or your brother or your sister or your best mate who's stuck in hospital was really important. So we did lots of printing, you know, off of photographs and poems and, you know, that kind of thing as well. We also encouraged through the virtual visit, and, you know, if they were doing virtual parties, you know, so lots of families did things like quiz nights virtually. And again, we really encourage patients to book out the iPads, you know, so again, they could engage with their families in that way when, you know, if that was something their families were doing. The other bit, and this is probably larger service improvement work we've been doing, you know, over the last 2 years, and especially looking at our health inequalities and the diverse population that we have here in Newcastle. So we have a lot of people who are being cared for and who are carers, who access our services, and we absolutely appreciate it and acknowledge the challenges that they face when either the carer or the person who's being cared for comes into hospital. And although we were addressing clinical needs, there was probably some of their social needs and emotional health and well-being, and probably financial needs that we could have probably been thinking about a bit differently to support patients. So what we did is we've worked with Newcastle Carers and Newcastle City Council, and we've seconded a post into the trust that is there to support and signpost patients or carers or people being cared for that are coming in hospital. And we wanted to do that at as much of an early stage, so those elective patients that are coming in hospital, whether they are the person who are the carer or the person being cared for, being able to contact our hospital carers information advice worker and thinking about the impact of that admission for them and the people at home, and putting that kind of support in place at a much earlier stage. Our carers worker can also give advice on things like benefits and signpost to benefits advisors. So again, you know, thinking about a lot of our families are living in poverty and they're worried about the person coming into hospital, what will happen to their benefits? You know, how can I visit because I need to get the bus, but I haven't got, you know, bus fares, all of that kind of thing. So our Alistair, who's our carers information advice worker, was out and about. We've put posters up, we've put information into coming in hospital, information to kind of say get in touch. And again, we saw huge numbers of people accessing that service, you know, to be supported during their pathway. The other bit, and it'll be again no surprise to anybody, is that our patients who are deaf or hard of hearing often feedback that access and services can be a huge challenge, and that often they won't access services because they haven't had a good experience, which then has a negative impact on their health. And we work really closely with one of our local stakeholders, who's a voluntary organisation called DeafLink, and we receive regular feedback about one patient's journey and the challenges that patients had, but also they work really closely with us to provide staff awareness, staff training, and do some local engagement with our local communities to kind of get some real rich feedback. And their main feedback was around access and services. So what we've done is we've funded in collaboration with two other organisations locally, so Northumbria Healthcare and CNTW, this Deaf Health Navigator project. So this is where patients who are deaf or hard of hearing can access this service that's is fully accessible. So they provide interpreters where they can go and get things like the letters written, read out to them, and translated, where the navigator service can contact our services to say, you know, the patient requires transport, but that's not been arranged for them. They can double check to see if an interpreter's been booked and who will that be, and are they available on that day. They can raise any questions on behalf of the patient, you know, so I am worried about coming in for my scan, and these are the questions I've got. So again, we can reassure patients at a much earlier stage and involve them within their healthcare rather than being reactive to the problems and the challenges that they're facing. So trying to put that support in a much earlier stage. And again, we've had some investments into our learning disability team. So again, you know, we know patients with learning disabilities or family members with learning disabilities really struggle to access the services, but often disengage. So things like higher DNA rates, you know, sort of non-compliance with medical care, you know, and difficulty with communication. So again, there's been some investment there that every single patient who has a learning disability is flagged on our electronic record. And the minute that patient hits any of our services, whether that's community, whether that's emergency healthcare, or whether that's planned healthcare, that flag goes through to our learning disabilities team, who will reach out to the patient and the family to kind of start considering what reasonable adjustments can be put in place to ensure that pathway for those patients are as seamless and as accessible, and hopefully with the attempt to improve that experience from the beginning of their journey to discharge. And then the other bit around this was during COVID, I think we absolutely acknowledged, and well, prior to COVID and during COVID probably just made us acknowledge even further that our reading age in Newcastle's 9, is at the age of 9. So again, kind of making sure those patients had information that was available to them in a way that they were able to understand that. So we had a lot of staff shielding during COVID because of their own health. And what we asked them to do was review some of those patient information leaflets that have probably been around for longer than we'd like them to have been around, to make sure again they were accessible and written in a way that patients would be able to fully understand them. And we also went into a contract with IDO Healthcare, which is a national provider of information leaflets mainly around surgical support and information for people coming in for surgical interventions. And I think not one of those probably had an impact on how we were able to get such good feedback in our national inpatient survey. I think altogether, they might have impacted. We continue looking at new service improvement models, especially for our most vulnerable patients. I think one of the challenges for the organisation is that we have relied on charitable funding to implement some of these posts and projects. And I think, again, like everybody else will be experiencing, with cost improvements, it's going to be how we sustain some of those posts and prioritise going forward, sort of where we're all going to have limited resources. And it's about have we empowered staff over the last 2 years to be able to continue with this model of care, and have they got the right information and access to signposting, rather than being dependent on one single person, because I do worry, when we sometimes roll out projects, that it's a kind of a one post project, so then it's one point of failure as well as one point of success. So, that's the work we are concentrating on now to make sure we've got a sustainable model, and that staff are being trained to be able to deliver on things like accessibility for deaf patients and support and people who are carers or being cared for. So that's some of our challenges going forward.
Thank you both very much for going over kind of your process to approaching the survey results and what your priorities have been over the last year. You were talking, there's quite a lot of different initiatives that you've implemented in response to COVID, and I really love the sound of the bronze, silver, gold. I know that's a very common approach that quite a few organisations picked up. But is there anything that you have taken through the changes to practice, or the implementation of programs over COVID that you've decided to keep on now moving forward?
We've stepped down, so we've stepped down our bronze, silver, gold. What we have done is we have now what's called a weekly stand-up. So every Monday morning, our executive chief nurse and our medical director and our chief exec invite so teams and our staff to stand up, and that's where we'll have our key messages. So again, we've got a shared vision and value. It's an opportunity to raise any immediate concerns, but also to help plan for the future. So within that stand-up, we will look at things like bed capacity, activity, impact on patient experience, incidents, sort of research. So I think research has got a huge scope, sort of going forward to help us understand the impact of COVID and how we restart some of those services that have historically just happened for a long time. So it's a similar model. We also have things like matron, sort of meetings on a weekly basis, clinical directors meetings, looking at things around governance, that kind of thing. So I suppose what I'm saying is that the bronze, silver and gold, we're kind of duplicating at a more local level, and adopting that within our governance framework as well going forward.
I think from a practical point of view, with the visiting restrictions being lifted as well, we've now got these iPads on the wards, so we're talking to staff and considering how we repurpose those, what we'll do with them. It might be surveys, it could be used for interpreters. I think one of our physios has mentioned showing patients videos of exercises they want to do. So we're going to make use of those to continue to, even though visiting's back in place now.
And I think the only other one, Hanan, for us, and again, probably similar, you know, across the country, is that we did very, very limited telephone consultations and virtual consultations. And actually, we are absolutely embracing that going forward, because for some people, that's more preferable. And, you know, so people who it is more accessible for some. So that's not to say that all of our patients will be offered telephone and virtual, but we'll absolutely be keeping a hold of that, because it has worked for some, not for others. I appreciate for some patients it's made a more negative impact, but I think, yes, we will be keeping a hold of that and embracing that and improving that going forward.
Thank you. So I'll open it up to the floor. Are there any other questions that people have?
It's Kate. I'm at Addenbrooke's. Caroline, we've had some contact in the past, I think. Not questions really, but really interesting to reflect how similar what you've been doing in Newcastle is to what's been happening in Addenbrooke's in many of those areas that you picked out. And even down to yesterday, I had a conversation with people about how we might repurpose some of our iPads as well. So thank you, really useful. I've also jotted a lot down, as Mark had. So yeah, I'll take this away.
If you've got any ideas, Kate, we're happy to share ideas.
Yeah, thank you. That's good.
Thank you.
Well, thank you both so much for joining us today. It really has been very, very interesting. I also have a page full of notes that are being added in here. And I just want to say thank you again so much for your time in joining us. I noticed that you popped at the end some contact details if people do want to get in contact or have any questions. This video will be made available afterwards. So thank you both so much.
Thank you.
Thanks, Hanan.
Thank you.
Bye.
Bye-bye.
Bye, everybody.